Thank you for joining us. So this is the first session out of 3. Thank you all for registering. And today we're going to talk about awareness and basic knowledge of intellectual disability. So go ahead, Erica.
Sorry.
Great. So we want to thank the following groups first. We have this project is funded and implemented because of a really generous grant from the Arizona Developmental Disabilities Planning Council, or ADDPC. We also want to thank Northern Arizona's Institute for Human Development and all the work that they've helped us with in getting this off the ground. We, throughout the past year, have been working with parents who have intellectual disabilities as part of an advisory board. And so we'd really like to extend gratitude to them. Without their voices, this project wouldn't be what it is today, and it wouldn't be very authentic. We also want to thank our other advisory board who were home visitor supervisors. So from Arizona, we've had 3 different supervisors work with us to make sure that the information we're offering is pertinent to you all. And then last but not least, we have been interviewing home visitors throughout the year and really trying to learn about their perspectives and experiences, and to bring those voices into the presentation. So we really want to extend our heartfelt gratitude to all of them. And if you're interested in being interviewed, please contact us at the end of the presentation and we can get you information about how to do that. So, all right. And now for our introductions. Our team, we have a really wonderful team with lots of talented people on it. We all work at the Institute for Human Development here at Northern Arizona University. My name is Sarah Clancy. I am an occupational therapist, and I've worked in early intervention for the past few decades throughout Northern Arizona, including Flagstaff, Hopi Reservation, Navajo Nation, and different communities throughout Arizona. So I'll pass it on to Erica Capizzi.
Hey everyone, my name is Erica. I'm a social worker. I also work at the NAU Institute for Human Development and I'm part of the Navajo Nation Early Intervention team. And I've worked throughout Arizona as a social worker and done a lot of in-home work, including child welfare, and now get to be part of this project.
And the learning objectives today there'll be 4. The first one is to describe the defining characteristics of intellectual disability, what that actually means, so we can all be on the same page and have a universal understanding. The next one will be to name 3 common myths about parents with intellectual disabilities. Then we'll talk about common challenges that parents with intellectual disabilities face. And finally, we'll describe considerations for home visitors working with parents who have intellectual disabilities. So before we get started, I just want to make sure nobody has a question, or are there any questions, or are you hearing us and seeing the slides okay? Great. Okay. All right, go ahead, Eric. And Erica will be the presenter today. So thank you, Erica.
All right, so we'll start with just talking a little bit about what ID is and isn't. We'll start off with some statistics, and I'm going to go ahead and read the contents of every slide for those of you that find that helpful. If you need me to stop or slow down for whatever reason, don't hesitate to speak up. So intellectual disability affects about 1% of the population. 85% of those affected have a mild intellectual disability. We'll talk a tad more about that later. ID, like so many things, is on a spectrum of mild to profound. And when we're talking about parenting, we're usually talking about mild ID, occasionally moderate, depending on the supports. So we're really going to be primarily dealing with talking about mild intellectual disability. Another statistic, males are more likely to be diagnosed than females. The difference in sex can be partially explained by X-linked causes of the disability, such as Fragile X syndrome. It's also important to note that socioeconomic factors contribute to rates of ID in children. And that's complex, and we're not going to dive into all of that. But rates are higher in children living below 200% of the federal poverty guidelines. All right, mouse issues. So in 2010, there was something called Rosa's Law. It was signed by President Barack Obama. At that time, it changed references to mental retardation. Sometimes you see that as MR in writing in federal law to intellectual disability. And after Rosa's Law, diagnostic manuals such as the DSM and ICD made these changes as well. Intellectual disability, or ID, is the term most commonly used by medical, educational, other professionals, and advocacy groups. Other diagnostic labels may include intellectual developmental disorder or disorder of intellectual development. You might also see IDD instead of ID. Like we said, we had this lovely board of parent advisors, and we had 4 of them. They all are comfortable with intellectual disability and ID, and that's what you're going to see most often. Down in the bottom corner here, you see this spread the word. That's actually a hyperlink. So we will provide these slides on our PATHS website eventually, and there's a bunch of links in here that you guys will be able to click on. So this is a campaign called Spread the Word to End the Word. It was involved in the advocacy work that eventually led to Rosa's Law. They have now taken on a more broad mission around inclusion, but they did play a big role in that at the time, and you can read more about them if you are interested. So for those of you that aren't familiar, the DSM is the American Psychiatric Association's Diagnostic and Statistical Manual, 5th edition. It was released in 2013. There was a revised edition in 2023, but that didn't include any changes to ID. So the DSM has 3 criteria for diagnosing intellectual disability. The first one is deficits in intellectual functions. So reasoning, problem solving, planning. Oh, sorry about that. Abstract thinking, judgment, academic learning, and learning from experience. The other criteria is deficits in adaptive function. So acquisition of practical knowledge, interpersonal communication, social judgment, personal care, money management, task organization, or the day-to-day functions. Then the third criteria is that the onset of the both intellectual and adaptive deficits occurred during the developmental period, which is now age 22. Due to the brain, the more we understand the brain, the more we realize it's continuing to develop into the 20s. So these same symptoms that would present for the first time after age 22 would be assessed and diagnosed differently. So plain language is communication your audience can understand the first time they read or hear it. The Plain Language Writing Act of 2010 defines plain language as writing that is clear, concise, well-organized, and follows other best practices appropriate to the subject or field and intended audiences. So we went ahead and made a little bit of, as a means of giving an example, made a plain language definition of ID. And we did run this by our parents who felt comfortable with it. So we've got having an intellectual disability means it can make it harder for someone to communicate, learn new skills, or take care of themselves. People with intellectual disabilities may need extra support to live, work, and participate in their communities. So you can, again, those orange underlines are hyperlinks that you can click on later to get more information about plain language. Some of our parents also wanted to make sure everyone understood what person first language is. I imagine many of you are familiar with that, but that's instead of, for example, saying somebody who is intellectually disabled, it's an individual or a person with an intellectual disability. So them as the individual comes first. And we'll discuss the use of plain language for parents with ID more in our our subsequent trainings. So here's another way of talking about people with ID in a respectful manner, particularly parents, and acknowledging their uniqueness, just like the uniqueness of everyone else. So like we said, ID is on a spectrum, like so many other things, right? So it's going to look different for every single person and every single parent. This comes from the National Research Center for Parents with Disabilities out of Brandeis University. You can click on there. They have a lot of great resources for providers and parents, including some of their resources are available in a plain language translation or option. So though all people with intellectual disabilities share the diagnostic criteria for slower learning, longer processing time, and increased support needs in daily life, each person's skills and interests are unique. Some parents struggle with making appointments, while others may need help knowing how to respond to a baby's cries more than they do keeping appointments. Needs vary widely, and the only way to be effective in supporting these parents is to learn what their individual needs are. Okay. Causes and factors contributing to intellectual disability. So where does it come from? Why do people have it? Intellectual disability is almost always the result of something that occurred during the pre and or postnatal phases. So some of those examples are genetic causes, Down syndrome, Fragile X syndrome. There's many other genetic causes. Also fetal alcohol spectrum disorders, birth injuries, such as an umbilical cord injury affecting the brain, maternal infection, and preterm birth. There are causes later in childhood, such as traumatic brain injury, infections that would cause brain injury as well. And for many people, the cause of ID is unknown. It simply is part of who they are. And there's not really been, it's not really been able to be pinned to any one thing. I'd like to make sure it's clear too that understanding the diagnosis and or cause isn't always important when working with parents. You will often work with parents who've never been diagnosed or don't entirely understand what's going on with them or why they struggle. So it's important to pay attention to those individual needs. And we can tailor our work to their individual needs without that diagnosis if we're asking questions and paying attention and listening. We have 4 myths that we're going to go through and kind of debunk those in the process. We also ran these myths by our parents who felt that they were accurate and things that they've encountered and felt comfortable with our kind of reframing those and felt that that was appropriate to them. So our first is that people with ID cannot be good parents. This is of course not true. People with ID have a desire to be parents just like people without ID. People with ID also experience the same array of emotions as people without ID and have the same capacity to love their children, family, and friends. It's important to note that the severity of an individual's ID may impact their ability to parent without supports. That can certainly be the case for some parents with ID. Family, friends, and community play a crucial role. And again, it's on a spectrum, but people with mild and occasionally moderate ID are typically able to parent, often with support from family and friends. And I also really wanted to point out that requiring support from friends and family is not in itself a child welfare issue, right? Many parents rely on support from others to be able to parent their children in the way those children need. And that's true for parents with ID as well. Requiring family to live with them full time is not in itself a child welfare issue. It's not a safety issue if they have those supports in place. Next myth is that people with ID will always have children who also have ID. So because ID is often caused by a genetic disorder, some parents will pass that trait on to their children. However, many causes of ID are not genetic, like we saw a birth injury, for example. And not all genetic disorders are passed on to children. And even more, some children are born with a genetic disorder that wasn't present in either parent, kind of like a random mutation. Next myth, people with ID are not able to work or contribute to society. People with ID are not only able and willing, but interested in working in their communities, just like people without ID. There are also people with ID who choose to or are not able to work, just like parents without ID. They're still contributing to society by raising their children, loving their friends and families, volunteering, advocating, etc. So at the bottom, you can see a couple of links. Our parents on our advisory board really wanted to make sure people knew what Nothing About Us Without Us is. Nothing About Us Without Us is a slogan that came to use in the world of disability activism in the 1990s. And it's basically saying that no policy should be decided by a representative without the full participation of those affected by the policy. And some of our parents with ID or other disabilities make a partial living, or if not a full living, doing that type of work and advocating, for example, joining boards like ours. And then there's also a link to the law in Arizona that kind of outlines the rights of people with ID. And like so many things, there's a lot of gray language there that's open to interpretation and subjectivity. So therefore, there's still quite a bit of discrimination in the workplace for people with ID, regardless. Last myth is that people with autism also have ID. We found in our work that there's often confusion out in the community and the general world about the difference between the two. So basically, if you took 100 people with ID, some percentage of them are likely to have autism, maybe somewhere around 10%. We didn't put stats in here because our parents didn't feel comfortable with the stats. People with ID have historically been left out of research, and so there's not a lot of trust in the statistics around it. But if you were to look it up, you might find somewhere around 10%. And then if you took another 100 people with autism, a higher percentage, more than 10%, will likely have ID, maybe up to 50. Again, like there's a lot of work to be done in that world. I will say though that the terms like neurodiverse and neurodivergent apply to both, to autism and ID. Okay, so child welfare is super important, and we're going to talk more. We'll talk about it in every training. It's very much a part of the daily lives of parents with ID, kind of in their mind all the time. And all of our parents brought it up so much that we wanted to really dedicate some time to that. So parents with disabilities, particularly those with intellectual disabilities, are reported to the child welfare system at a higher rate than non-disabled parents. And there's not evidence indicating that these higher rates are due to an increased need for welfare involvement. In other words, they're getting reported simply because they have a disability. No safety issues had been identified. So in addition to higher reporting, they also experience higher rates of removal of children from their home and termination of parental rights. There's a couple of reasons. You can kind of put them into two categories, more or less. One, we have the exposure bias, where parents with ID or any disability for that matter are interacting with more professionals, doctors, social workers, home visitors, etc., who are all mandated reporters. So the more they're exposed, the more likely it is that somebody's gonna decide that or worry that they're not able to parent. And because of that, a lot of parents will avoid professional interactions for a fear of being reported. And that sets off a whole other cascade of problems for them and their children. The other is discrimination. So there's just some really unfair practices within the system, lack of appropriate interventions, assessment practices and tools, not looking at considering a parent's access needs. Sometimes they just need help accessing something in order to be able to parent better. And they're not an unsafe parent. They're just stuck. There's also just general bias among you'll see among workers or supervisors or the kind of the system in general, and a belief that they can't or shouldn't parent. So here's a map. Again, there's a link. This goes back to Brandeis University that we talked about earlier. So you can see, and this is a map that shows what the grounds are for different disabilities around termination of parental rights. So in Arizona and all the other states that are green, these are the disabilities that can be used for grounds of termination of parental rights are ID, psychiatric issues, and substance use. And so there's a lot of work to be done there. And you can look up that and read more about that. There's also a link to the Arizona revised statute that outlines there's some language in there that points out specifically intellectual disability as a reason for termination of rights. Okay. So next, we're just going to talk just a tad about what it means to parent with ID, what it feels like, what it looks like in the lives of these parents, and what they're up against. Starting in pregnancy. So parents with ID have historically been involuntarily sterilized. This was repealed in the 1970s, which was only 50 years ago. So if you really think about it, it just wasn't that long ago. There's still a lot of work to do. Data from other countries indicate that pregnancy rates in women with ID are similar to those without ID. So again, people with ID are wanting to parent or are parenting. There's no data in the US at this time. People with ID face disparities in healthcare and therefore have poor health outcomes. And part of that, like we talked about earlier, is that avoidance of professionals for fear of reporting. There's just a whole cycle there that they're up against. Also, access to birth control is more complex for women with ID. Accessible information about different options is not always offered to women with ID. Also, women with ID are more vulnerable to relationships that are controlling and or abusive. So there's a lot going on there that they're up against before their children are even born. Barriers to physician visits during pregnancy and pediatrician visits after birth. Again, the child welfare involvement and limited access to transportation, financial support, just being able to access these services that they have a right to in general. So they're off to a really difficult start at the beginning of a pregnancy. And therefore kind of a trajectory of poor health for themselves and their children can kind of take place. These statements all came from the voices of parents with ID who were part of our advisory board. So these are some of the biggest takeaways of what a parent with ID experiences and feels. They often feel isolated. They must navigate multiple systems, which can be challenging for any parent. We all are kind of familiar with the way systems are siloed and how difficult it is to access different ones for anybody. And they're having to access even more of them, and on top of that being limited. They're very fearful of child welfare involvement. It kind of lives within them all day. They often feel judged by professionals, and they can learn new things like any other parent. It might just take a little bit longer or require more repetition. In our next two trainings, we're going to talk more about ideas, strategies, tools, etc., for home visitors when interacting with parents with ID. But we wanted to leave you with a few things to take away into your work. Many of you are already aware of a lot of these things throughout our interviews. It was really clear that there's some really, really lovely and mindful practices going on out there already. And those, some of those are in here, things we actually heard from home visitors. So these are coming from home visitors and parents. So caseload, I know that's loaded, for lack of a better word, but a parent with ID will likely need more time than a parent with ID without ID. So, and we, you know, I'm a social worker, so I totally understand the complexities around caseload, and I don't expect caseloads to change because I just said this. But it is something to think about, depending on the flexibility of the agency, the worker, the supervisor, that if there is a known parent with ID, they are going to need more time. And so if that worker is really going to be able to serve them in the way that they need, then they might need to consider that. Parents may avoid programs like evidence-based home visiting because of the exposure bias and fear of child welfare and feeling very vulnerable having people in their home. Many parents with ID are fearful about people who will be walking through the door and have a fear of badges. And it's likely that, well, I'm not going to say likely, there's a good chance that a parent with ID also had stuff going on in childhood in which badges were bad and meant that something bad was going to happen. And so there's probably a lot of trauma there to be considered. Patience goes a long way. Every single one of our patient or our parents really pushed for that. Like, just please be patient. Like, that's all that was kind of the biggest piece of advice or what they would like to see people do. Prioritize the relationship. And again, we saw that so much in our interviews with you all as the home visitors already doing that work. And focus on their strengths because they have many, and we'll see that kind of in the case study we're going to talk about next.